move this to the next level of questioning to Dr. G.V. Rao sir, you do endotherapies. See, it is very, very pertinent. Now, endoscopy is replacing many surgical procedures into an endotherapy-based procedure. So, the indications for endotherapy is not now questioned. Let us talk from the situation. You have a COVID positive patient who is indicated for an endotherapy. You have tests in hand. They have RT-PCR positive. 4 to 5 days after RT-PCR positive situation, patient needs a pancreatic endotherapy. What will be your approach towards this scenario, sir?
Now, this actually a very good question, Kanagwal. Actually, now we categorize these patients as to mild, moderate, and severe risk at having this infection. So, any of these patients, now we're saying a COVID positive patient actually tested positive, obviously it's a high risk. Now, these patients, now we have to take both from the patient point of view and from the hospital healthcare workers also, complete personal protective equipment has to be available. It has to be done preferably in theaters with negative pressures, if possible, or designated theaters with full protective equipment under general anesthesia. And we have umpteen number of modifications that they're using to cover the head end of the patient during this procedure to prevent this aerosol from spilling over. And also we should have good suctioning equipment in the theater. Make sure, especially if you're doing something like wall of necrosis, make sure that you have adequate suctions, multiple suctions available in the theater, minimal number of people, under full general anesthesia, full protection to both the doctors and to the patient. These procedures have to be done. Because right now, though there is no data to show whether this COVID is seen in the pancreatic necrosum, but there is adequate data to show that COVID is found in the peritoneal fluid. Once it is found in the peritoneal fluid, we take it for granted that even the pancreatic necrosum or the fluid should have some COVID. So these patients have to be taken with utmost care, both during the procedure and after the procedure, and have to take all possible precautions to dispose this properly. These are very, very clear indications actually that we have to do. So as far as possible, we try to avoid any of these elective endoscopy procedures. But a wall of necrosis, symptomatic, worsening general condition, it has to be done. It has to be like an absolute surgical procedure with all PPEs and all precautions taken.
So how do you handle the post-procedural reprocessing component of these scopes, sir? Because it looks like they also have to follow the same amount of standard of PPE, which is being advised by the people who are during the procedure.
Yes.
Post-processing, the reprocessing of the equipments and disposables also look like a big challenge.
Yes.
How do you handle that part of it, sir?
Now, see, it's a very good question actually. Now, this I would personally believe that any of these centers, actually, if the patient has to go for an endoscopic treatment for any emergency, any endoscopic therapy, these patients have to be referred to only centers which have this proper cleansing, disinfecting equipment, which can be absolutely used to disinfect both the scope completely and also the theater. I do not advise these procedures be done in any peripheral center which does not have ways and means to disinfect the protocol-based endoscopic disinfection system. So I do not think that should be done in any hospital. They should be done, I think, only maybe a few, restricted number of centers across the country would be having this. So unless and until you have all this, I don't think you should be performing these endoscopic procedures.
Point is